Temporomandibular Disorders TMD. Temporomandibular disorders are conditions affecting the jaw joint that consist of one or more of the following. Number 1, myofascial pain, that is pain in the muscles serving the jaw. Temporalis, masseter, medial and lateral pterygoids, neck and shoulder. Pterygoid spelling Pteryggoids. Pteryggoids. Pterygoids. Second one, internal derangement of jaw joint, that is dislocated or displacement joint disc or injured condyle. Third, degenerative joint disease, example arthritis. Pathophysiology and etiology. Causes include rheumatoid or osteoarthritis, scleroderma, ankylosing spondylosis, trauma, teeth clenching or bruxism. BRUXISM, bruxism, that is teeth grinding. Neoplasms, acute infections such as parotiditis, dental infections and peritonsillar abscess, congenital anomalies and tetanus. Any mental or physical stresses can induce and exacerbate symptoms. Above factors result in inflammation and muscle spasm of the temporomandibular joint. TMJ. Clinical manifestations. Pain at the joint, temples, mandible and masticatory muscles worsens with jaw movement. Referred muscle spasm of the neck, trapezium and sternocleidomastoid muscles causes discomfort. Clicking or crepitus from grating or popping of the joint. Limitations of movement, dislocation or jaw locking. Headaches, earaches or tinnitus, even dizziness and hearing problems. Change in the bite. Upper and lower teeth do not match in the normal, comfortable way. May experience deteriorating oral hygiene, halitosis from limited oral opening, trismus, making dental hygiene difficult. Many experience difficulty chewing due to limited jaw excursion, resulting in altered diet and weight loss. Jaw clicking alone is common and requires no workup or intervention if asymptomatic. It probably represents a displaced joint disc. Diagnostic evaluation. Diagnosis can usually be achieved by history and physical examination without extensive testing. Dental and TMJ X-rays may or may not be helpful. Occlusion analysis evaluations for macro-occlusion of the jaw and teeth in the bite position. Computer tomography and magnetic resonance imaging are usually normal unless there is underlying derangement changes, fracture or neoplasm of the jaw or cervical spine. Arthrography, that is joint x-rays using dye. Arthroscopy, that is endoscopic invasive joint examination. Management. Initial management employs jaw rest, soft non-chew diet for 2 weeks plus avoiding extreme jaw movements such as wide yawning and gum chewing. Anti-inflammatory analgesics medications such as ibuprofen. Application of warm, moist heat or ice packs. Muscle relaxations may be prescribed. Therapeutic night guarded or splint. No reline macular occlusion or joint disc and to optimize muscle relaxation. Physical therapy for gentle stretching and relaxing exercises with or without ultrasound. That is deep heat therapy to enhance analgesia and muscle relaxation and to promote local tissue metabolism. Transcutaneous electrical nerve stimulation TENS reduces muscle spasm of head, neck and back and reduces pain. In general, conservative reversible measures above are employed as long as possible before progressing to invasive surgical management. First one, arthroscopy, investigational procedure to visualize joint, reposition disc, lice adhesions and or debride joint. Reserved for conditions not improved by medical managements. Complications include cranial nerve, seventh one damage with facial paralysis and paresis, perforation of the external auditory canal, piercing of the middle cranial fossa, surgery to remove the disc or reshape bony prominences. Last one, complications include malocclusion, cranial nerve, seventh one damage and infection. Thank you.